Thank you for the opportunity to have me here today. I have a topic that probably most of the providers get to see on an infrequent basis, and the complex decision-making that goes in between interventional and the surgical team and the heart failure team trying to make a decision of what's best for the patient. Part of the thunder was stolen last night for the discussion over the our last session of last night. So I might not be having more to add, but we'll integrate this as a case for last evening's discussion. 68-year-old male who presented with shortness of breath to an outside hospital who had an acute infraposterolateral MI presentation. And he underwent a cardiac cath that showed multivessel disease, and he had a selective femoral angiogram that was considered for evaluating for support devices, and that made it prohibitive at that time in the outside facility before he was transferred to our center. This was the initial presenting EKG at the outside hospital, and the patient did not have any chest pain associated with this, and like I said, the symptoms were almost 4 or 5 days old. These were the initial presenting labs, and the patient had findings suggestive of multifocal pneumonia and pulmonary edema, renal failure, congestive hepatopathy. To summarize the events, summarize the findings, his EF was 25%. He had a moderate to severe MR with no caudal rupture, and his right heart cath on arrival showed an elevated filling pressure, normal cardiac output on supportive therapy and the setting of a mixed shock. And his left heart cath showed 100% proximally occluded lesion. LAD also had proximal 80% lesion. And RCA was a co-dominant small vessel. Going on, this picture would not do justice to the MR, but it's an eccentric MR and an ischemic MR without any mechanical complications suspected, and his LV dimension was close to 5.9. His coronary angiogram, there's 2 images there, shows the proximal area narrowing in the LAD and a mid-LAD narrowing and a diagonal ostial. And you see the left circ is cut off at the proximal segment. And at the first image, parasternally, you can see a faint flow towards the left circ with possible collateralization. And at the second image at the bottom, you can see left to right collaterals as well. And this is demonstrating the LAD again. So, like I said, the patient was transferred from an outside hospital. There was no PCI consideration at the outside hospital, and their discussion was quoting the oat trial of delayed presentation. And day 3, the patient presents with to us in mixed shock. An axillary impella was placed with ongoing shock lever and use of unloading his LV. And this helped to back off on all his vasoactive medications with resolution of his shock liver, and he was extubated. However, the next day he did develop polymorphic VT in the absence of suction events, and there was addition of more antiarrhythmic therapy. He was re-intubated, and these were his hemodynamics on P8 support and dobutamine and levofed. And day 6, the CT surgery and interventional team reconvened for decision making. And the decision was there is no, the big decision is there's no optimal revascularization strategy. And consideration of high-risk PCI in this patient with focus of possible culprit lesion and possibly a stage PCI, and versus CABG, which can alter the course in a patient with high risk in the absence of mechanical complications. So the clinical decision-making after a heart team meeting was to attempt an LAD revascularization for more in favor of hemodynamic improvement and to wean off the impella. The left circ was occluded, and the concerns was for high-risk anatomy and possibly jailing the left circ while stenting the LAD, and that could compromise things further. And in interest of renal dysfunction as well, they opted for a delayed revascularization of the left circ. And the events that followed, he had an IVUS-guided PCI of the LAD with provisional stenting, and following which the patient did not improve. He continued to have VT. He remained on triple therapy, and his hemodynamics were optimal on support, but every time they tried to wean the impella, he had hypotension with elevation of filling pressures. He had continued to have leukocytosis, and his renal function initially stayed stable, then further progressed. He remained intubated, and the family was available by bedside. While we apply all that we learned last evening in the last session in culprit shock with focus of the culprit vessel PCI versus an ad hoc multi-vessel PCI, and with no hard data for early CABG in these patients with risk of increased mortality. And the other option in this patient, the part 2, after attempting revascularization, is consideration of advanced therapies. There is a cohort study that we know from the Intermax data that shows that the LVAD patients in acute MI cardiogenic shock do have fairly good outcomes, just like our non-MI patients. And we did have a palliative care introduction in this patient. I actually, for the sake of discussion, would like to have this area of discussion before I discuss the outcome of the patient. So what I did not put out up front is that the patient was a foreigner and not a U.S. resident, and just like we had the discussion earlier, we do not have the resources to support these patients. There was a delay in decision making for those reasons, trying to get finance involved and stuff. So this patient was switched to renally dosed integralin, and that kind of complicated his triple therapy regimen, and patient had GI bleed and ischemic colitis. And then he had recurrent VT requiring cardioversion, and his renal failure progressed to a point that he required the decision for renal replacement therapy and possible LVAD consideration came up, and the family decided not to escalate care and return to comfort care. With that in place, I would like to have a discussion back as to what individual programs would do in the decision making of patients with multivessel disease in cardiogenic shock and unable to wean off their devices.
Dr. Nathan, we haven't heard much from you on the panel. What are you thinking about this case?
Yeah, hearing from me is usually not the problem. My wife's pointed out that I need a mute button. It's a tough case. Let me just ask you, what did you guys end up doing with the circumflex?
No, so that was a decision for a stage PCI, and when we started on the decision for would he need a VAD discussion up, we switched him to integralin, and then he had this bleed, then the whole topic of left circ revascularization was suspended for the beam.
Right. So, I think, you've got support, and he's certainly unstable. There are aspects of that circumflex that didn't look like a CTO, to be quite honest with you. I think it would have been, it's a large territory. You've got a small RCA. You've got an infralateral MI as your presentation. One wonders whether, it was highly stenosed to begin with and then just sort of closed off at the very end. So I think, when your back is against the wall, when you have limited options, both in terms of, social issues as well as, medical comorbidities, that I think you have to go for broke. I'm not being critical, of course. This is a very tough case, and, you guys, did the best you could to try to get him through this. I can tell you at my institution, my surgeons would want to have nothing to do with this. This would be just an academic discussion. We, sort of checkbox. Heart team met, we discussed it, shock team met, all teams met, and please, good luck, Godspeed. In the lab, I think that it would have been perhaps worth an attempt to get that open, see if that would stabilize him electrically.
But so I certainly agree with that. We had that conversation yesterday, didn't we, about patients in cardiogenic shock and complete revascularization in that setting. To add an extra little piece to this, and I understand his social situation compromises that, but there now are a number of case reports, including in CCI, about doing emergent mitral clip in patients like this in order to get further hemodynamic stabilization. And so the question, I think, to expand that would be doing something to the mitral valve, whether that's percutaneously or surgical as well.
So it seemed like for the mitral clip that this patient would fit into the French study as opposed to the COAPT, where there was not disproportionate LV dysfunction in relation to the extent of the MR, and so
I think if you're looking chronically, Mike, that's true. Yeah. I think if you're looking at the acute stage where revascularization is occurring. And again, what we're trying to do is to stabilize the patient. It, as I said, is controversial.
Right. Well,
But I think if you revascularize the patient, you may not be in that situation. It's just something to consider.
Yeah, and not to have a journal club on proportional versus disproportionate MR, but compared to the French study, there is a heart failure steering committee in the context of appropriateness for the clip, right? And looking at this guy with pneumonia, acute presentation, renal failure, I don't know how much we're going to get. I think you went big with the Impella, which is good. So, you don't need a durable VAD. You want to see how this guy's going to do. Complete revascularization would have been, the recommendation. But at our institution, in terms of surgical considerations with, Impella device, with the pneumonia and renal failure, and they would have punted as well. And so, tough case, great presentation. And I think the clip's an intriguing idea, but, the potential benefit in the context of this patient profile, I'm not so sure. I think worth having, certainly, but certainly would have been excluded from any study that guides us.
Would any institution consider LVAD in this patient who's intubated and on renal failure?
So we know the sicker they are going in, the worse outcome, and ventilatory status carries one of the highest hazard ratio. And you have a VAD, you can flow, right, 5 liters, and you're supporting them. So we certainly wouldn't take them for a durable VAD in that scenario. But we continue the Impella support to facilitate decision-making, most importantly with the family, and to see if he gets better.
That's an excellent discussion. I think we need to move on. Could you